And now to Dr. Eyre. Carlos is going to introduce her. So Carlos, you want to come up?
Yes, absolutely. Welcome, Dr. Eyre. It's an honor for us to have today here as our visiting virtual professor, at least, but hopefully in the future, we'll have you here with us physically. So right now we have over 80 participants from 13 different countries. So we usually have multiple people joining from different institutions around the world. So again, it's an honor to have you here. Here we have a little resume on Dr. Eyre's career. And it's been amazing with getting her MD, PhD degrees on the University of Cincinnati and doing residence in that same institution. She went to do a fellowship at University of California, San Francisco in 2011, and then moved back to University of Cincinnati with an assistant professorship. And then she moved to Detroit to Wayne State University and the Henry Ford Health System, where she has received multiple honors and multiple positions, including the residency program director, as well as the vice chair for operations, and currently is the co-director of functional stereotactic neurosurgery. And as we can see here with selected honors and awards, she's been awarded with as the best doctors in the 2 different cities in Cincinnati and Detroit. We have a few selected publications for Dr. Eyre as well, showing her trajectory early in her career. And we track her, of course, with the Scopus, and it's impressive what she has been able to achieve currently with an H index of 23. So thank you very much again, Dr. Eyre, for joining us. Her presentation for today will be entitled Advances in Neuromodulation for Epilepsy. So we're really excited to hear from you today. Thank you.
Thank you so very much for having me. It's really, truly an honor. And this has been a wonderful opening to my morning to hear all of the amazing things that are going on at Mayo. It's actually really just uplifting to hear about all of the work that's going on and the many conferences. It looks like I do need ability to share my screen though, in order to be able to pull up my presentation.
You should be able now. You should be.
Great, thank you. All right. Oh. Let's try and get to the beginning. How's that? Hopefully that's my opening slide.
Yes, ma'am.
Wonderful. So I thought I'd give a little bit of an overview, and in some ways this is a little bit of, I guess, a walkthrough in terms of how I've been looking at neuromodulation, how I've experienced neuromodulation for epilepsy since way back in the days when both Sanjeet and I were in Cincinnati, and how much has really changed and evolved over that time, and how I think about patients who are potential candidates for surgical treatment, because it has been quite an evolution just over this last decade. And then depending on time here, I will potentially also be able to kind of tap into a discussion of the work I've been doing in terms of understanding why patients choose or don't choose epilepsy surgery. So these are my disclosures. So, when we thought about, certainly when I started out in training for treatment of refractory epilepsy, we're talking about 20 to 30% of patients with seizures who remain refractory despite a 1 to 2, or really 2 independent medications at full dose plus 1 combination. And so that was always this long, a little bit treacherous path to see whether or not there was going to be an option for surgery. So, we had to try and identify where the seizures were coming from, and then determine, is that something that we're able to actually do something about? Can I actually take a patient with, do they have a lesion on their brain that's a specific location that matches with where their seizures are coming from? And is that something that's now safe to remove? But that approach really did leave us, and more importantly, left patients with a lot of limitations, because not all partial onset seizures or epilepsies are well localized, I should say, not just be localized, but can be well localized. And just because a seizure onset zone is localized does not make it resectable. Patients have different thresholds for deficits they may or may tolerate, but we are all, I think on the same page to say we're not going to take somebody to surgery when we know that we perhaps are going to, definitively remove their speech. So this then becomes a problem for those patients who continue to be refractory to treatment, because once a patient has tried second and I actually need to change my nomenclature here because it's recently changed from anti-epileptic drug to anti-seizure drug. That after the second one, adding that, the chances of seizure freedom goes down to about 10 to 30%. If they remain refractory and you add another, then it's 5 to 15%. Once a patient has gotten to trying 5 different seizure medications, the chances that they become seizure free, it approaches 0. So we have a significant population of patients who have been without a definitive treatment for their epilepsy. And particularly as we get in the adult population, SUDEP matters, right? There is a significant risk of SUDEP, and it gets worse in patients who are adult and who are having, in particular, generalized epilepsy or secondarily generalized seizures, and in particular, anybody who has them in their sleep. So what do we do then for those roughly 1 million Americans and many, many, many more, if we think about this around the world, with drug-resistant epilepsy? Is sort of this blurry pathway, and there's 2 issues here. So on one hand, even if we talk about the more upfront versions or the clear pathway of somebody has something resectable, mesial temporal lobe epilepsy, there's probably, at least in the US, about 100,000, 200,000 people with drug-resistant epilepsy who are surgical candidates. But in the US, there's only roughly about 4,000 or so surgeries a year. I think this has opened up a little bit with some of the new therapies I'll be talking about, but still there is a huge treatment gap for patients. And some of that has been from lack of referral, but there has also been insufficient options. The core today of stimulation has come down to VNS, RNS, and DBS, which I will talk about in sequence. So VNS has sort of been the stalwart. It's been the default option, right? Somebody was not a resective surgery candidate and was continuing to have seizures or wasn't tolerating their medications, and vagus nerve stimulation is what we offered to them. And that and today, even, I will tell you, and I'm sure Sanjeet experiences this as well, we all have where patients just feel like this is the safer option rather than considering a brain surgery. And so having that surgery in the neck where we put the electrodes on the nerve seems like a good place to start. And we know this is not a cure. Only about 30, maybe on a good day, depending on the type of patients, like a Lennox-Gastaut patient, can experience about 50% reduction in seizures. One caveat to that is that reduction can be individualized. Some people experience a frequency reduction, some a severity reduction, some find the magnet to be helpful. But really, this is not a cure-all for many patients, but it is a very important adjunct. It is very much still a part of our armamentarium for patients. We do have to consider the risks. But the next on the plate of, or the menu, I should say, of options for patients has been responsive neurostimulation. So that has actually really only been available roughly not quite 10 years in terms of FDA approval. And it requires a good localization in the seizure onset zone. So this picture here is an example of a patient who's bilateral temporal onset epilepsy. RNS is a wonderful option for such a patient where you have bilateral and you don't want them to, obviously you're not going to take them for bilateral hippocampectomies, and the ongoing seizures is going to cause them memory problems as well. Now, one of the things that has also helped in our use and application of RNS, and maybe I should just step back for a second here. So with RNS, the it does require that really good localization. And the reason for that is the sampling of the electrodes needs to be in the seizure onset, as it is now pattern recognizing the changes in electrical activity of the brain that herald the onset of a seizure, so that at the earliest signs of that electrical pattern starting, the device will automatically give a responsive burst of high frequency stimulation to hopefully short circuit to stop the seizure. So it offers us a lot of good benefits, both in a direct and very local treatment to the seizure. It also means that we get really good recordings of the seizures that are happening. And I will tell you as an aside, in a patient such as this one picture of the bilateral temporal, we've really found that patients where we think they're maybe dominant on one side or the other will spend months at a time kind of flip-flopping between having a predominance of seizures from one side, and then they go to the other side for a while and sort of back and forth. So it's also been a great tool for learning more about patients with epilepsy. But we do have to have that localization, and the move back towards using stereo EEG electrodes to localize our seizures. We fortunately have a robot which allows for very efficient placement of these electrodes for seizure mapping, has been an immense tool in our localization and being able to offer patients the treatments such as RNS. So our pathway oftentimes will involve a patient going through a phase 2 placement of most often stereo EEGs. We can even do a mapping through the stereo EEG electrodes, such as the speech, and then use that information to determine whether or not somebody can move towards a RNS placement. So what are the outcomes when we see this? So this is from the original trial where patients were implanted, as many of us would expect, particularly given our experience in deep brain stimulation, that just putting a probe through the brain can have some calming effect. And certainly for all patients, they had a decrease in their seizures following the placement of the electrodes. But then once that period sort of washed out, we can see the patients who were not getting stimulation revert to their prior baseline area or baseline frequency of seizures, whereas patients who were receiving the responsive neurostimulation continue to have a downward trend. And then once the stimulation was turned on in the sham group, they then gained the similar benefit. Another thing to note that I think this tool is really teaching us is that there's something about an ongoing stimulation, that a neuromodulation that is changing the circuitry over time. If you just look at the treatment group, there is this kind of ongoing downward trend before it starts to level out in the seizures. And we see the same thing when it comes to a VNS patient. If you look at studies where optimal settings were at, say, 6 months or a year from surgery, and then seizure frequency was noted at that time, and you continue to follow those patients out without changing any settings, there tends to be some slight continued downward trend in the seizure frequency. So what we're really learning is that neurostimulation is doing probably way more than we really understand, and that concept of just sort of circuiting the seizures, there's more to that. There are multiple ways in which we can look at placing the neurostimulation, the responsive neurostimulation. The current system has 2 ports, so 4 contacts in each. So I showed you previously an option where we put depth electrodes into the hippocampi bilaterally, but we all know there are cortical causes of seizures, and you might think about, say, in this example, a seizure that might be near speech. And so cortical strip electrodes can be placed around in whatever configuration you like. The FDA has allowed for placement of up to 4 electrodes, even though only 2 can be connected at once. So oftentimes, once we've completed a phase 2 and we found that there may be 2 areas that are particularly active, but another 1 to 2 that seem to play a role, we we'll hook up the two most active when we go to put in the implant, and then we'll keep the other ones kind of in our back pocket. And occasionally, as we monitor the seizures, then we will change which electrode might have to go in and just unplug and swap around which electrode we're using for monitoring. So I have a few patients where we've had to do this, and part of it is, as I mentioned before, the seizure focus that seems to be dominant can change over time. And again, down at the bottom, you can see that we have this sort of seizure trend as the months go on of ongoing decrease in seizure frequency when we have a good target. As with every other aspect of epilepsy, location does matter. And again, patients with temporal epilepsy tend to do better than other areas of the brain. The responsiveness to just about any treatment tends to be better in a temporal onset seizure than it is for the other regions, but we still do see a mean change in seizures that over time in patients, regardless of the location of their seizure onset. So RNS, as I mentioned, we really have to have a location, and for now a number of years, I guess there was probably a gap of 5, 6 or so years between this coming out and then now what I'm going to talk about next in terms of deep brain stimulation for epilepsy, where we had a significant group of patients that we now were able to offer a stimulation treatment for when they were not a resection candidate. But then we were also finding that we still had patients who might have multifocal epilepsy, and either the source was just a little bit too broad, or things bounced around so fast that it was hard to know exactly which of the targets, or there were maybe more than 3 or 4, that we weren't sure which one was going to be ideal to be able to put in a RNS system. And so fortunately, deep brain stimulation was ultimately approved for treatment of epilepsy. And I have to say, this has been a very long road to getting to this, because the pivotal trial was published in 2010. And I still remember being in Cincinnati with Mike Privatera, who was on the FDA medical board at the time, and they had approved back in about I guess it would have been 2011, 2012, that deep brain stimulation be approved at that time, and the FDA said no. And luckily, Medtronic, who's the company who presented or who studied this, persisted and continued to follow those patients out. And the long-term data was, I think, really what convinced the FDA to allow us, or to bring this to fruition and bring it to patient care. So deep brain stimulation long been, available for patients, first approved in the US, I think about 1997 for tremor, and then subsequently for Parkinson's and other targets for Parkinson's disease, and then under an humanitarian device exemption for dystonia. So as a functional neurosurgeon, this seemed like a very natural thing for us to be able to do, and somewhat confusing as to why we weren't able to apply it for our patients. And the difference here is that now we're really looking at almost, I think of this as sort of a circuit breaker, right? So instead of trying to hit the one individual box in the circuit breaker where, the electrical error is happening and flipping that one switch, we're sort of interacting with that whole box, hopefully, in targeting the limbic system, and in particular the anterior nucleus of the thalamus. So this is, post-op images of the location of the electrodes, and we tend to think about it in terms of more frontal located onset of seizures, but I will say we have patients who are multifocal. Really, any multifocal patient is appropriate for this. And the pivotal trial was the SANTE trial, where, again, as with RNS, you put electrodes through the head, everybody's seizures go down. And then once we turn on the stimulation and we leave one group without the stimulation, theirs tend to rise back up to their prior or almost to their prior seizure frequency, whereas patients who are undergoing regular active stimulation continue to have persistent decrease in their epilepsy. And this paradigm it's interesting because it's quite a bit different than the stimulation that we're used to for deep brain stimulation for Parkinson's disease, et cetera, which is a constant tonic stimulation. In this, it is a cycled stimulation, much more akin to the VNS cycled stimulation. So the initial parameters are 1 minute on, 5 minutes off, and that persists. And then it's just a matter of what the amplitude is for these patients. Over the long term, patients have continued. Again, we're seeing that same trend, that there's something about the ongoing stimulation of the brain in these circuits that tends to lead to some progressive ongoing improvement in their seizures with ongoing stimulation. The quality of life has also been improved in these patients, as you would, hopefully you would expect, I would expect, and luckily has come through in terms of patients finding that their attention, memory, expression, just their anxiety, total mood have improved. And that, again, I would expect just based on not having to live with the ongoing stress of seizures. So impacting their life. Let's see. One thing that we have been finding, or has been found, I should say, in deep brain stimulation in the anterior nucleus, is that the location really does truly matter. There's the intersection of the anterior nucleus with the mammolothalamic tract. And when the stimulation is just anterior to this junction or at the anterior border of this junction, a very high responder rate, whereas if it's posterior to this, with a very high non-responder rate. So that is critical, and one thing I know I look at when I've placed the electrodes in post-op to be able to determine which electrode is the one that I am going to turn on for stimulation, because it is a monopolar stimulation paradigm. So just as another way of representing that if we're looking at this particular area where we have the junction of the nucleus and the mammolothalamic tract, that there seems to be this hot spot relative to those patients who do not respond to the treatment to the same degree. One of the things that has a functional neurosurgeon who had been doing DBS for quite a long time to get used to is sort of getting over a little bit of my upchuck response of the concept of going through the ventricle to place these electrodes. So, there are some situations where placing electrodes transventricular was, something we would do, but it's for the most part in my training, that was sort of the big no-no, right? You avoid sulci, you avoid the ventricles, you just want to have a nice straight path to the target, and whether it's GPI or STN or VIM. But for this target, the ability to really optimally get that location, as I showed you, being able to be in the responder versus non-responder case is really important. And on the left, you can see a transventricular approach versus on the right, a periventricular or avoiding the ventricle approach. And what they've seen is over and over again, it's harder to get the electrodes really into the sweet spot when you take that pathway that's extraventricular. So now, having done several of these and my upchuck response slowly calming down and doing these surgeries, realizing that there is a little bit of a difference, that because I'm going through almost perpendicular into the ventricle, and then the end of it is the target, that the skiving and disruption of the epinema that I've always worried about has been less of an issue. On a rare occasion, I know my colleague in particular at Henry Ford, Dr. Schwab, has done these work from a posterior approach in order to get to that same location. But doing them extraventricular, really, it's hard to get a good target. So since it looks like I might have a quick minute here, I will just kind of close this part and then make a little bit of commentary on one of the things that I have long been thinking about in patients with epilepsy, and that is how we approach them. So, uncontrolled epilepsy, as we all know, results in a decreased quality of life, decreased life expectancy. Unfortunately, over this last decade, we've been able to provide a number of new options that were not previously available for patients, and part of that because of their not really truly being surgical candidates in the traditional sense. I will say I have found there's some acceptance in some ways of having a stimulator placed rather than a big, open surgery, that sort of scary thing of having their brain opened. That has allowed some patients to accept another intervention. But the reality is that we still have an underpenetrance in terms of patients who have under controlled seizures or uncontrolled seizures, and those who potentially could be who could benefit. I was going to take a little bit of a side note. My little commentary on VNS, which is that sometimes success is in the eye of the beholder, and this goes both ways. I think about traditionally patients with VNS, only the patient here in the middle with the 70% reduction in seizures following VNS would have been considered as a responder, would have been considered as a success to VNS. But having personally worked with patients in the other categories, for instance, at the top, a Lennox-Gastaut patient, where really their main reduction was in atonic seizures, even if they didn't really meet that 50% threshold for total seizure reduction, or a patient who had a dramatic reduction in their post-ICL state from 24 hours to 15 minutes, that for those individual patients, there were benefits to them that as a clinician, I did not upfront realize. And so I've sort of taken a little bit of that into my thought process about how I approach discussing with patients what it is that they're looking for out of seizure surgery or out of their seizure treatment in general, and how I can potentially meet them where they're at. And so one of the things that I've been looking at is, if I can go back here, is something called a discrete choice experiment. So this, you've probably interacted with this type of experiment in some place along the way. It's very commonly used in marketing. And the idea is, as we all know, we go to the store and we think about, I'm going to buy product A versus product B. And there's a whole variety of attributes to that product that we put into our decision making, but how are we valuing those relative to one another? And so in this, random example, talking about a turf characteristics, one option might have, a winter kill probability, a water need, a cost, and another, a different set. And if you only had those two options, or versus not picking, what would you pick? And when you take those attributes and you change the numbers by a little bit on every iteration, you can statistically analyze which of those individual attributes are the ones a patient or an individual has put the highest value on. And you can do this in healthcare. And in some ways, I think we do this when we're talking to patients in our clinic, and we just don't really realize it. So if we think this is an example of sort of a tumor treatment, we might think about time to tumor progression and things like what some of the side effects might be, but a patient might be more worried about what their skin looks like, or whether they have to come in for an infusion. And so we will often have that as a conversation in the clinic with the patient, who say, is this worth it to you, given that these are the risks of the treatment? And we're kind of asking the patient in that moment to tell us which of those are most important to them. And what I've been working on kind of in the early process of is trying to understand this for an epilepsy patient. And the way in which in order to perform one of these experiments, excuse me, really requires identifying the key issues that patients consider in their treatment decisions. And so I did a variety of focus groups in order to determine which were the best which factors were the ones, then have given a variety of rank order, basically asked the patients, these are the things that in the focus groups people suggested were important to them, and deciding whether or not they would undergo a seizure surgery, and then ask them to rank them. And so now I'm sort of at the point of sorting through this. I still need to collect few more patients, but it's been interesting to me to put this together as and then hopefully we'll do the larger sorting experiment to really nail this down so that we can understand where patients are at and then better meet them at that place in terms of talking about whether surgery is right for them and what the benefits might be. So consistently important so far has been, as you might expect, not wanting to have seizures, risk of loss of function, and particularly with memory. But what I thought was sort of interesting is things like, whether their family was on board, or the immediate parts about getting through surgery were really consistently not on their list. So I'm hoping that with this ongoing work, I'll be able to pull together some more of the factors and use that as a tool to, again, as a community, I would hope that we'll be able to use that in connecting with our patients to get them the most optimal treatment for their epilepsy. So with that, I will stop sharing, and I am more than happy to take any questions.
Thanks for an excellent talk, Doctor. We really appreciated that. I'm going to see if some of my epilepsy colleagues can start off our discussion. I see Dr. Tatum raising his hand, so get ready.
Thank you, Dr. Ayer, for that nice talk. Our group has been very interested in neuromodulation for some time, and we have a crackerjack team with Dr. Graywall and Dr. Middlebrooks and the rest of our group in the epilepsy service. And I know you've worked with Dave Burdett. We've focused in on dual stimulation, and a lot of these neuromodulatory devices we speak about as singular agents, but in fact, the very bulk of them now, I'm sure you're seeing people come back with dual types of stimulation. I'm curious about your experience. We just published ours in World Neurosurgery, and I wonder if you could speak towards the frequency and the utility of dual neuromodulation, and also some of your experience outside of the standard targeted sites that you're implanting.
Yeah, absolutely. So when you're talking about dual stimulation, I mean, I can think about that in more than one way. On one hand, I think about that as there's always that group of patients who has the VNS, and then we add a central stimulation.
Right.
Yeah, and so absolutely that has been a group. In fact, I consider it's been a little bit of a debate in our institution, because there's some that feel like we should only be moving, or there's always that argument that we have to prove for insurance reasons, whatever, that somebody's failed VNS before we go to another form of stimulation and adding that on. Personally, I feel like there are patients out there where we honestly, we know that RNS or DBS are going to be helpful for them. I don't think we have to put them through the VNS necessarily as a prerequisite to those others, but we certainly have a lot of patients where we see that they have the benefit of adding the two of them together. So I would totally agree with that. For our stimulation targets, the RNS has largely been just targeted where we have less often gone to using a circuit-driven use of the RNS itself. I do have patients with central median stimulation for DBS, and have picked that more in patients with where we feel like the balance of the circuitry has been a little more posterior rather than frontotemporal, and has seen that work incredibly well. I know my colleague up at Spectrum has a series of patients where they've done both PM and focused RNS, either location at the what is considered the seizure zone plus a central stimulation. We have not, and that has seemed to work. I think my question about that, anytime you're sort of putting all those in, is which one is the one that's actually doing it, and how much of it is the best when you get to the combination. And the only way to really do that, which we don't always have the patience for, is to implant it all, stimulate one for a period of time, track it, switch to the other, and then consider both of them together. And I don't think that, at least hopefully you do, I would love to hear about it, have more information on patients where that step-by-step approach has been taken, so we can see what the true benefit is of combining those types of stimulation.
So we haven't done a crossover study, which is what you're alluding to. I think that's a great idea too. But what we have found is that more of our DBS VNS patients compared to the RNS VNS patients have had a first response to VNS, and then all of them continue with dual stimulation as opposed to RNS, which have been more likely to have intracranial evaluations and discontinue some at the time of surgery, the VNS using RNS in monotherapy. It's been an interesting kind of combination in terms of evaluating the differences between the two. I know your colleagues at Spectrum, I know Dave Burdett has also implanted the pulvinar central median anterior nucleus of the thalamus in DBS. Are you doing that, or are you finding significant differences? There's only a few that have done this so far, and I'm just curious as to your experience.
We've primarily focused on anterior nucleus, and then do have one or two CMs running around, but and have focused those on using the DBS platform, and then using the targeted stimulation through RNS. And when I think about that crossover study, I agree with you. I don't know that I necessarily feel like you have to do that separate when you're talking about a VNS and central, but I think that we're getting to the point where we're going to have more and more patients that have put a central target, like an ANT or CM, plus a your onset target, like hippocampal, and that turning all of those on at once doesn't really give us a clear answer as to what's doing what, and without having designated periods of time where we're testing one versus the other. I mean, to me, it's the exact same thing in a DBS patient for Parkinson's disease, where they have STN and GPI leads, right? If I don't actually know which one's doing what, and we just kind of light them all up, then one, we don't know what's doing what, and two, I'm not sure that gets us the answer about how to best program them all.
Thanks, Dr. Tatum. Thanks, Dr. Ayer. Dr. Ayer, question from one of our international participants was, have you ever seen DBS actually exacerbate seizures or drive seizures?
I have. So actually, this is one of the things where I was so lucky, I think, because it became front of my mind that I was with Mike Privatera while he was complaining about the fact that the FDA did not accept the first paper, because the main thing was there was an outlier in that data set. And in that data set, there was one patient where on the cycle, right, it's 1 on 5 off, on the cycle, the patient was actually having a seizure. And so their seizure numbers went way up. And once they turned that down, that patient actually had a really had a good response. So we learned from that. I think by the time the following, the subsequent papers came out, and then we were putting into practice, a lot of people forgot about it. And I'm just totally random chance, my very first implant was one of those patients. So I went ahead and I turned her on to the full 5 volts, and she's sitting there, and then she's like, and she's looking around, and I can see her start going off, and then it just went away, and it was fine. And it's like, okay. And then we're just going to sit here a little bit longer and see what happens. And it was happening on the 5-minute cycle. So I turned it way down. I've now, and it's interesting, if you go to conferences and listen to some of the people who've been using this at a high volume, like, I don't start at 5 volts anymore. I start at like 2, 2.5. saves battery life because a lot of patients don't need to get all the way up to 5, as it turns out, and you're lowering that risk of having the seizures be set off.
That's awesome. And then Dr. Faisa has a question, so let's see if he can.
Hey, thank you, Dr. Ayer, for the nice talk. My name is Anton. I'm one of the epileptologists. So my question is, the SANTE trial is actually mostly for focal epilepsy patients. And in your experience, like, have you had much success? Because that's something we talk at our epilepsy conference almost every other week about the role of DBS in a primary generalized epilepsy patients. If so, is it more with, ANT, or do you have more, success with centromedian nuclei implantation?
I think the answer is yet to be fully defined. I think that my bias based on the literature that's out there is that the either more posterior onset or the ones that have a little bit more of that generalized feel to them, that CM is the target that I would choose. And I'll admit the first patient that I implanted that in was absolutely in that category where had a little bit more of that generalized feel to all of the recordings and everything they were looking at, but still had multifocal things that we could say there's definitely different areas done great. So I do think that's going to be the next thing, but we have a lot more work to nail that down and be able to make the argument for it.
Thank you.
I think one question I had, and it comes up in our epilepsy conference all the time, is putting in four RNS electrodes in right from the beginning. What's your threshold to switch? So I mean, if you start with your 2 that you think are your high yield, what would make you go back in and switch? That'd be
honestly,
it's
been their seizures. So it's been monitoring what's been going on when they're exhibiting seizures that are not being captured by the electrodes, right? When that, the patients, as can mark when it is that they're having a seizure and they're keeping their seizure diaries. And then you can go back in and actually read all of the data. And if it's not being captured, then that's the thing. That's what biases it. So on occasion, and actually I have a patient right now where we implanted bilateral hippocampal plus an insular on one side, and now is having seizures on that were breaking through all of that. And we were debating about whether or not to connect the insular and which one do we disconnect. She ended up in the epilepsy monitoring unit again, and it turns out that the surface electrodes are pointing to her now showing signs of yet another seizure focus that's not either of the other, looks different than everything else. So now we're actually talking about switching to a DBS paradigm.
Yeah.
So, sometimes the patients tell us oftentimes the patients tell us what we need to do for them.
Yeah, it's always interesting, and it's always an evolution, right? So that's the thing. Where you start is not where you end up.
Absolutely.
Any other questions, guys? If not, we'll let Dr. Ayer move on with their day.
I just want to thank Ellen. Thank you. What a beautiful time. You can see there's a lot of more people can spend all morning asking you questions, and you see people from all over the world. You recruited over 13 countries, over 80 participants this early in the morning, different time zones. So it's a great pleasure to have you. And I look forward to catching up with you later today and see how we can build more bridges. And thank you for meeting with the residents and the faculty, and for dedicating your morning to us. And hopefully one day in the future, we will have you come and visit us in person. We'll do a course on epilepsy, modulation, and all that amazing stuff that you guys are doing.
Thank you. Of course, this has been truly amazing. It's just absolutely wonderful. It's such an honor to be here.
And of course, Dr. Tatum and I hopefully one day will convert you to the onco-epilepsy field, for which we're very passionate about. Good. All right. Thank you, Sanjeev, for directing this. We really appreciate everybody from around the world, and then we'll catch up later. All right. Go to your next meetings. I think that there are different links right there, Ellen, that Andres has set up for us. All right. Thanks, everybody. Bye-bye. Thank you, Sanjeev. Bye.